Okay, please, anyone in the audience, if you see someone joining the session, please add them or allow them to join. I will not be able to do that while sharing my screen. Can you all see my screen? Good. Okay. So, right away, we're starting with a quiz. And Maryam, I'm gonna go by names now, even though I don't know who are there. Maryam, can you hear me? Yeah. Okay, so the first question goes to you. The number of productive hours worked by nursing staff with direct patient care responsibilities per patient day. This is considered what kind of measure? Structural measure, process measure, outcome measure, or a composite measure? You cannot? Okay. The number of productive hours worked by nursing staff with direct patient care responsibilities per patient day is a structural measure, a process measure, an outcome measure, or a composite measure. Your best guess. Structural? Anyone else has another answer? Outcome? Any other doubts? Okay, now we have all. Okay. So this is what happens when you are in the exam. You start putting one answer and then you start thinking and rethinking and rethinking. This is talking about the number of productive hours. Was that? Somebody was saying something? Okay. So this is the number of productive hours worked by nursing staff. This is talking about staffing, availability, the how many nurses do we have to care for our patients. So this is a structural measure. Yeah, it's not measuring a process. There is no like the time between this and that. There is no process in here that's being measured, and this is definitely not an outcome because it's just things that should be available for the hospital or for the nurses to be able to deliver the care. So sorry. So this is a structural measure. Correct, Maria. The next question, let me take Hannah. Hannah, are you there? Okay, I cannot hear anything from Hannah. Uh, wasn't there? Okay, Sabita. Yeah. So this is the question. The senior leaders of a hospital are prioritizing performance improvement initiatives for the coming year. Which of the following tools will be most useful for this purpose? Pareto, cause and effect, affinity, or stratification? Pareto. Why do you sound so unsure? I was like, Savita's gonna get it like that. Okay. Anyone wants to guess why it's a Pareto chart? Anybody remembers what's a Pareto chart? Adina, do you remember what's a Pareto chart? Okay, the 80-20 principle. Last time I asked you the same question. Yes. So the 80-20 is that 20% of the causes or the reasons or the issues you have would be the reason of 80% of your problems, right? 20% of the causes result in 80% of your problems. So think of an hospital that is looking at performance improvement initiatives for the year, and they studied last year. There is definitely certain number of things that if they work on and they try to improve, then 80% of their problems will be resolved. So that's why you do a Pareto chart. If I have added here another option, for example, the what do you call it? The impact and effect analysis, or the what was it? The oh god, the prioritization matrix. That was gonna be really confusing, and because both are the same, it's either the Pareto, or you could be using a prioritization matrix where you look at the effect and the impact, and then you study the which option is the best. Okay, this is quite easy. Adina, I will ask you this time. Which of the following graphs? No, that was a follow-up question. This is now an actual question. Which of the following graphs is most appropriate in displaying the root causes of adverse events that have occurred in a hospital system over the past 10 years? Uh, what about line chart? Uh, okay. That's okay. So line charts are also over time, and we will be talking about line charts quite a lot today because we're talking about quality measurements. But line chart is the one that comes in the form of dots. So like it would be dots that are connected by a line. That's fine. I'll be showing it later. But it's also over time. Bar chart is also over time. Let's see the others. Let's see the others. Anyone has any idea what's the answer? And I did not say wrong or right, okay? So I'm just asking for more ideas. So histogram, Hana, and the reason being, you changed immediately. Okay. Okay. Line chart, no, no. Okay. So the first answer is the correct answer, the bar chart. First of all, the bar chart, and maybe I have to go to session one slides, but maybe a bit later. The bar chart and the histograms looks like each other. The histogram is usually used only when they are numerical. It's very specific. It only works with numbers. And it has a wide base. It's usually a range of things that you're looking at. Bar chart could look at numbers, could look at categories of things. It's like certain instances of things. And here we're talking about categories because we're talking about the causes of adverse event over a certain period of time. So the line chart is not categories. The line chart is the same data displayed over time. The bar chart could be showing you an aggregated data of one thing in the forms of bars in one chart. So for this one, when they're saying that you want to display the root causes of adverse events, so these are categories of things that occurred in hospitals over the past 10 years, and this is over time as well. So you could be showing the different bars. Najla. Okay, so which of the following is the main goal of implementing lean management in a hospital? Create an organizational culture that is receptive to lean thinking, distinguish between value-added steps from non-value-added steps in any given process, eliminate waste, identify key process for Kaizen projects. Okay, that's your answer. Anyone else has interest? Eliminate waste, Hannah. And who was the other person who said eliminate waste? Maria. So the correct answer is eliminate waste. Actually, if you look, all of them are related to lean. When we talk about lean management, yes, we want the organization to have a culture that's receptive to the lean thinking. We need to distinguish between value added and non-value added steps so we can remove the non-value added steps. We need to eliminate waste and we need to identify key process for Kaizen project. Kaizens are the continuous improvement projects within a certain area. But when they say the main goal is eliminate waste. Okay. And this is how sometimes they confuse you. They give you things that are all related to the same question, and you'd be asking yourself, which answer is it? That's how the questions are. It's not mine. I actually tried to look for example questions and mainly CPHQ questions to get you those. So these are the kind of things you will be getting in the exams. Okay. This is another common way of how they do the examples. They write for you a scenario and then they waste your time actually because you are bound with time. They waste your time by long scenarios and long answers. So in this scenario, it says that the chief executive officer of an acute care facility wishes to know the difference between total quality management, TQM, and Six Sigma. The healthcare quality professional should inform him that TQM can be implemented on its own, while the benefit of Six Sigma can only be realized when it's combined with lean method. TQM loosely monitors progress toward goals, where Six Sigma ensures that investment in quality produces the expected return. TQM focuses on compliance with performance standards. Six Sigma focuses on world-class performance. TQM is a management philosophy where Six Sigma is an improvement methodology to reduce variation in a product or a process. And this question goes to Rabab. Don't break anything, Rabab. The fourth one, TQM is a management philosophy, whereas Six Sigma is an improvement methodology to reduce variation. Could be. Any other thoughts? Anyone? Fourth one only? Okay. Yeah. So you see, they sometimes give you very long answers with, detailed, what you call it, statements that you really need to read. And in the stress of the exam, you need to read and read again to make sure that you're getting the right answer. But yes, TQM is a management philosophy. And what would it be? Unfortunately, I can't see who's all in the room. Uh, Mariam again, I'll ask you. What did we say about TQM? Do you remember anything? Could be. Anything else you remember we talked about? Anybody else remembers what did we say about TQM? That's in general, quality management is improvement across time, but this was mainly done in our first session, I believe. We talked about TQM, and it was when we were talking about the history of quality. We said excellent, Adina. So the keyword for TQM is the involvement of everyone from management to frontliners, and it focuses on more of a wider system issues rather than just the individual product or services concerns. Thank you very much, Adina. That was an excellent answer. Okay. Uh, I don't know whom I did not ask. Rabab, maybe you can help me. Anyone I did not ask? I did not torture yet. Hannah, okay. And this might be an easy one for you. A hospitalized patient died shortly after being administered with medication intended for another patient. Which of the following tools is most appropriate for facilitating root cause analysis? That's very easy for you, Hannah. Prioritization matrix, Ishikawa diagram, pie chart, or Pareto chart. Oh God, how come? Mm-mm. She, I, actually the question was written as fishbone diagram, but I changed it to Ishikawa just to make it more difficult. So yeah, so Ishikawa is another name for the fishbone diagram, root cause and effect analysis. All of them is the same thing. So it is Ishikawa diagram. Okay. Now, whoever wants to answer, the dimension of quality or performance that's addressed by introducing a rapid response team in a hospital is continuity of care, efficiency, effectiveness, prevention, and early detection. Sure, go ahead. Okay, so I will not ask for any other answer because you've explained it perfectly. Yes, a rapid response team is a team that addresses or sees patients before they deteriorate and go to higher level of care. And this is one of the preventions and early detections. Excellent, Adina. Okay, the next question, again, whoever wants to answer. In an improvement project to reduce the wait times in an emergency room, the time taken to be assessed by a physician is a process measure, an outcome measure, a structure measure, or not a suitable measure. Process measure? It is process. Yep, excellent. Okay, so a word, a space, is a term applied when the proper clinical care, hold on, sorry, there's a typo here. Clinical care process is not executed appropriately, such as giving the wrong drug to a patient or incorrectly administering the correct drug. This will be what? Underuse, overuse, misuse, or illegal use? Misuse. Excellent. Okay, another one of those very long questions that will confuse you during the exam. Crossing the quality chasm provided a blueprint for the future. What's crossing quality chasm? Before we go forward, what's crossing the quality chasm? What did we hear that? Yes. So this is the Institute of Medicine report that talked about to err as human and then crossing the quality chasm. So that provided a blueprint for the future that classified and unified the components of quality through 6 aims for improvement. Chains of effect. Yeah. Chasm. That was a report. That was a report that was released by the Institute of Medicine back in 2000, 2001. Remember, that was based on it. All the culture of safety practices and all came that error is human, and we need to focus more on the system issues rather than focusing on the specific person, blaming one person kind of thing. So it's a report by Institute of Medicine. So going back again, the crossing the quality chasm provided a blueprint for the future that classified and unified the components of quality through 6 aims for improvement, chains of effects, and simple rules for redesign of healthcare. The 6th aim of improvement viewed also 6 dimensions of quality, viewed also as 6 dimensions of quality. Which of the following is not one of those dimensions? Care center, patients, and excellent. Okay. The BDSA Performance Improvement Model is a method for continuous quality improvement to resolve a specific situation rather than organization-wide problems. BDSA stands for Plan, Do, Study, Act, Plan, Delegate, Study, Account, Plan, Do, Study, Account, Plan, Delegate, Select, Act. Yep. I was just playing with words, and that's what they do in some of those. Excess of patient IV pumps in storage is an example of which of the lean wastes? Waiting, processing, inventory, or transporting? Inventory. Excellent. The aim of Six Sigma is to eliminate something, while the aim of lean is to increase something. So what are those spaces? Defect and waiting, variation and waste, 3.4 DPMO and inventory, defects and value. Okay, defects. Any other answers? Okay, so true. Six Sigma eliminates defect and lean increase value. Okay, if I change the question and I made it, the aim of Six Sigma is to eliminate something, while the aim of lean is to eliminate something else. What would be the answer then? Variation and? To decrease waste, yeah. So the second one would be the correct answer. Variation and waste. Okay. So you started working in a quality department of your hospital, and the manager asks you to draw the process of the emergency registration to discharge in a physical graph in order to identify wasted effort or steps that do not add value for the customer. What is the drawing called? Fishbone diagram, lean management, value stream, defect analysis. Any other answers? Correct. So it's value stream mapping, and I left out mapping on purpose. So value stream mapping is a diagram that draws out the physical graph in order to identify wasted effort and steps And remember, when we talked about value stream map last time, it had cycle times and different waste elements that could be reduced. Thank you very much. That was it for the quiz. Now I'll just go to session 2 summary very quickly. We talked last time about, we were continuing with the chapter 2, which was the basics of quality improvement. And we talked about those 3 methods of quality improvement: plan, do, study, act, Six Sigma, and Lean. For plan, do, study, act, we said it's trial and learning methodology, mainly tested on a small scale, and it's usually done before any major changes are done to the whole system. One of the ways to actually decide what you will implement is by starting with the Nolan's 3 questions during the planning stage. And these would be: what are we trying to accomplish? How will we know that change is an improvement? And what changes can we make that will result in an improvement? And then you study, and then act. We talked about Six Sigma, and we said that the aim of Six Sigma is to eliminate defects and to reach a level of quality that resides in the 6 standard deviation of an average performance. And we showed in the graph what does it mean to be in the 6 standard deviation. And their aim is to reduce the error rate to be about 3.4 defects per million opportunities. So when you see DPMO, it's defects per million opportunities, which is equal to 99.9996%. And it's a data-driven process improvement methodology. We talked about the different Sigma levels. If it's a 1 Sigma, that means you have 30.9% defect-free. If it's 2 Sigma, it goes up to 69. 3 Sigma goes up to 93. 4 Sigma goes up to 99.4, while as a percentage, it's good. As a defects per million opportunities, it is really high, 6,000 defects. 5 Sigma is still 233 defects. And then 6 Sigma is the 3.4. Six Sigma uses the model called the MIC. So define, measure, analyze, improve, and control. Lean focuses on eliminating waste. And we say that removing waste, the waste is also known as MODA. And this was established in the Toyota production system. That's why they have a lot of Japanese terminologies attached to it. Kaizen, when we mentioned it, is also considered continuous improvement, rapid, relatively low, simple. It's based usually in the team, and it's done at the working area. And they focus on non-value added processes and removing them, eliminating them from the process. They focus around the customer needs. They always identify the value, map the value stream, create the flow, establish a pull, and then continuous improvement. We talked about the waste category under Lean. Defects is one example of waste. Overproduction is another. Waiting is another. Non-utilization of talent, transportation, inventory, motion, and extra processing. And we give an example on each one of these. We looked at the process, a lean process implementation before and after. So you could see if these green lines were the value added steps and the blue lines were the non-value adding steps. Removing the weights and the non-value steps makes the patient journey shorter and more streamlined. It offers the same value with less time and resources. And we say there is what sometimes people combine both Six Sigma and Lean into Lean Six Sigma, where they combine eliminating defects in a process with eliminating waste in and around the process. We talked about the value stream mapping, where we define all the waste times, the value times and the waste times, and the cycle time and the value added cycle time, non-value added cycle time, and we always aim to reduce the non-value added cycle time. And we ended it with the comparison of the 3 improvement methodology: plan, do, study, act; DMAIC, define, measure, analyze, improve; Lean focuses on eliminating non-value added steps; BDSA focuses on rapid cycles for improvement, while Six Sigma focuses on eliminating defects and customer-centric. Lean focuses on enhanced efficiency, eliminating non-value added steps, and reducing the cycle times. The ideal use for BDSA is for usually pilots, and when you have less time and resources. For Six Sigma, projects consist of an activity that's repeatedly with high frequency. So think about the million opportunities. Lean is in any process where it can be defined, and you could look at the non-value added activities. And then they talked about some tools that support each one of them. That doesn't mean that it's only specific to this tool. They could also be used in other tools, but they are commonly used within this tool. Under the Six Sigma, black belts, green belts, and so on are very specific to the Six Sigma process. We talked then about the commonly used quality improvement strategies. We talked about academic detailing. Anyone remembers what did we say about that? I think this was the last part of the session, so we might need to refresh everybody's memory about that. Education and training, true. So academic detailing is what we do usually as common quality improvement methodology, is that we go up to the units, to the frontline staff, we educate them, we tell them about what's going well, what's not going well, and how we can improve, and so on. Opinion leaders. Who are opinion leaders? Influencers. Mhm. So it is someone, yes, you can rely on their opinion, but they are also leaders without actually being leaders. It's those that you could use to influence departments or people to actually change behavior if you get their buy-in into what you're doing and the cause of your the quality improvement process you are implementing and so on. They would be then the messengers that would spread the message wider to their groups. Audit and feedback is the traditional process that we do, where we audit and then we provide feedback immediately to everyone. If someone is trying to join, please allow them to join. Reminder systems, we've talked about the things like what we have currently in the electronic medical records with reminders and alerts of things that we might have missed. Patient education, definitely this is involving the patient in the quality improvement methodology. I'm sorry. Just give me a minute. Case management, this talks about managing the patient case from uh, from beginning to end and making sure their situations are monitored. Re-engineering looks at looking again at the processes, studying them, rearranging them, and re-engineering them to a better approach. And then incentives talks about giving kind of encouragement for people to participate in improvements as they go forward. And then we talked about the different challenges for successful quality improvement: technology, structure, psychological climate, leadership, culture, and legal issues. And we gave example on how each one of them could be actually a barrier as we go to the quality improvements. That was it for session 2. Everything clear? Anyone has any questions before we move to session 3? Okay, great. Session 2, we're talking now. We're gonna do chapter 3 for today, and the objectives of this session is that we'll be able to describe the historical evolution of the science of quality measurement. We compare the characteristics of structure, process, and outcome measurements. We'll construct appropriate measurements for quality improvement projects, and then we will identify the necessary characteristics of quality measures, including reliability and validity. Okay, so we're going again to talk about the quality, the Institute of Medicine, IOM, that's the Institute of Medicine 6A. So the question to all of you is, we have those safety, effectiveness, patient-centered, timeliness, efficiency, and equity. Who can tell me what was the concept of safety, specifically if we're talking like in general, and if we're talking about quality measurement? Okay, excellent. So healthcare providers must take all feasible steps to protect patients from harm, including preventing medical mistakes and injuries. Okay. What could be a measurement that relates to safety? In this chapter, we're talking. What's that? Okay, so the not having any adverse events, reporting incidents is part of safety, definitely. All the medication safety data that we collect are related to safety, correct administrations, all of that. The lack of complications also comes under safety, true. Effectiveness. Oh, okay, I displayed the answer for asking. Fine. So effectiveness refers to how well a healthcare service achieves its intended purpose. Effective service are likely to be safe and provide the desired benefits for a patient. So remember when we talked about effectiveness last time, we said effectiveness is, for example, you get a medicine, the purpose of the medicine is to reduce your pain, and the medicine actually reduces your pain. That's effectiveness. You go to a doctor with flu, they treat you for flu, you become better. That's effectiveness. What could be a measure of effectiveness in healthcare? Could be, sorry, if, if you talk about the infection rate, like the hospital acquired infections, that's more under safety. But effectiveness, uh, that would come later. Hold on to that thought. No. Effective. Remember, we just say that this service is providing its intended results. So, Sabita, when you talked about measures, but you talked about things that measures complications that are not intended to happen, right? So that doesn't come under effectiveness. But if you say, for example, the number of patients whose hemoglobin A1C, diabetic patients whose hemoglobin A1C is within the required target of less than 6, maybe, or something, that would be effectiveness. You're treating them for diabetes, you're giving them medications, and you expect that their blood sugar will stay, their cumulative blood sugar as HbA1c will be less than 6 or within 6 or less, right? So that's effectiveness. Effectiveness is that whatever you're doing is actually producing its intended result. So anything that we do, all of those, for example, MI, core measures that we are collecting, that the patients have, they've reduced their chance, actually reducing the chances of some complications would be effectiveness, because that's what you will be aiming for sometimes in your patients. So effectiveness always focus on, did my treatment give the result that I was looking for? So any measure that collects data on how well your treatment was, that would be an effectiveness measure. Okay. Adherence could be, but again, adherence is more of a behavior that the patient takes. Say that again. Was it you, Hannah? I did not hear you, sorry. Okay. So effectiveness, we say focuses on the idea of the service or the treatment or whatever you offered providing or producing its intended effect or purpose. So if you are measuring, for example, if you are measuring, you are treating a patient who's diabetic and you want their blood sugar to be 6, for example. If you measure that and the patient blood sugar is 6, that's an effectiveness. You're measuring the effectiveness of your treatment. You're treating an MI patient and you want to make sure that the patient is, for example, had less number of complication as a result of their MI. Or you're treating a patient with high blood pressure and you want to make sure that their blood pressure is always controlled less than 130 systolic and less than 90 diastolic. So if whatever you're giving them treatment for is resulting in the outcome you want and you are measuring that, that's considered measuring effectiveness. Is it clearer now? Am I confusing everyone? Okay. Okay. What about patient-centered? Okay. So what could be a measure under patient-centered? Satisfaction, excellent. Looking at their satisfaction rates, satisfaction surveys, their views on the services that you offered. The patient satisfaction is one of the major patient-centered measures. And also, if you're looking at data like the actual the involvement of the patient in their care, their satisfaction with the type of education you're giving them, those kind of stuff will be under the patient-centered care. Timeliness, there is 1,000 measures about timeliness. In our quizzes, we just gave an example about timeliness. What could be a measure that relates to timeliness? Waiting time, definitely. What else? Definitely administering medications and treatment on a timely manner. Avoiding delays, definitely. So looking at, for example, that time from reaching to emergency to time of admission to the unit and stuff like that is also looking at timeliness. And also making sure that we provide on-time care as required is part of the timeliness measures. Efficiency. Now somebody answered the question, an answer that was actually related to efficiency and not effectiveness. What could be a measure of efficiency? Is that vaccination? So what did we say efficiency is? Okay. So that was, so Savita, the literature, that was the efficacy. It's not here, but the efficiency is what your colleague said. It is the resources, making sure that you are, you're not wasting any resources while getting the service that you want. So vaccinations do not come here because we're looking at the service versus resources used. Somebody gave that example, something that relates to resources. Efficiency. Anyone remembers? Uh, the staff ratio could be looking at efficiency, but it's more of a structural measure. So budget utilization, staying within cost, the utilization of the antimicrobials. The example I was looking for that someone of your colleagues said earlier was the length of stay. So the length of stay the patient stays in the hospital is one of the efficiency measures, right? You could have a patient, for example, previously we used to have a patient who needs appendectomy surgery, stay in the hospital for 3 or 4 days, sometimes even a week. Now patients for appendectomy surgeries do our same day surgery and they leave in the evening, right? So imagine how much of an efficiency do we have now on those type of surgeries. So the length of stay is one of the major efficiency measures when we're talking about healthcare. Okay, please admit whoever is waiting. Okay, equity. What could be a measure on equity? So that's true. That's that definition. But what could be a measure under equity? Definitely giving vaccinations and making sure that all patients are getting it, looking at wait times between a different class of patients and insurance types and seeing whether that affects the wait times, the other kind of decisions related to that. That is for the 6 aims. Then the next thing that they talk about in this chapter also is the characteristics for quality measurements, and these are actually as noted by the Agency of Healthcare Research and Quality, AHRQ. So they have those characteristics that they have defined for what's expected in the as data. So first of all is the standardization. Okay, what does it mean and standardization? What do you think? Okay, so getting the report the same way without variation, but between different providers. So let's say I'm collecting data on the compliance with the pain management policy. I go to the unit number 1 and I find that they are collecting data by looking at the patient satisfaction with the pain management. And then I go to unit number 2 and I find that they are collecting the data by looking at their files and how much were they complying with the policy. And I go to the unit number 3 and I see that they are doing quizzes and asking the staff questions about pain management and do they know the policy. Is this a standardized methodology for data? Maybe everyone, like within the unit, they are using standardized tools, but across the units, that's when we call it standardization. Is it clear or should I repeat? Okay. So standardization talks that the quality measures, whatever data we are collecting, is standardized, but here is the standardized across the different levels or the different places that are reporting the same data. So if I am reporting, for example, the same example I gave now about the pain management, the compliance with the pain management policy, I should have a standardized tool, and all the units in the hospital should be reporting the same thing, right? So if I go to one unit and that one unit is looking at patient satisfaction with the pain management, and I go to another unit and I find that they are doing quizzes for their staff, asking them about what do they know about the policy of pain management. And I go to another unit and I find them that they are doing a medical record review of the pain management practices. Do you think that this is standardized data? That's it. Yep. So standardization, exactly. That's why we should have the same tool, we should have the same definition. Specifically, if you see in the book, it's talking about a standardization at a national level. So this is even beyond. So let's now think bigger than just a hospital. Let's think in, for example, the DOH, when they are assessing all hospitals, they sent all the hospitals the same definition, and they ask them to collect the data the same way. There is clear explanation about when to include, what to exclude, who should be your target audience, how you should be pulling the data, what diagnosis codes you should be using. All of that is part of the standardization of the data, because when they want to compare any hospital to another, they want to make sure that they're comparing apple to apple, as they say, and they're not comparing different data types, right? Clear? So standardization refers that we are collecting the same data, the same way, with the same definitions across all the levels of reporting. If you're talking about standardization at the level of the hospital, then all the hospital units should be reporting the same data. If it's across the nation, then all the nation hospitals should be reporting the same data. Simple as that. Okay? I am worried, did I over-explain? It's clear. Okay, good. The next thing is the availability. So when you are collecting or you're selecting a measure, you would look at the availability of the data for the healthcare organization. Okay? It's simple. The data shall be available. It shouldn't be something that I cannot collect or I don't have or that's not even maybe belong or is relevant to me as a practice. Okay. It also means that the data shall be made available. So let's say I am reporting this to the DOH, I shall be able to also review the same data and have it available to me for revision across time. So it's very simple, it's very straightforward. Availability, you have the data, you are able to access it, and you are able to find it at any time. Okay. Timeliness. So timeliness here looks at that the measure is available, but here it is on a timely basis whenever the organization needs it. Okay. Can you think of an example when data might not be timely? Anyone can think? Did I lose you guys? Okay, so if the CEO asks you for the data for the month of, what was it, September, will it be available with you? Like if you are the one collecting the data, should it be available with you at the time? It should be. So the timeliness only says that whenever the need or the consumer or the user needs the data, they should be able to find it. definitely, like if I ask you today is the 22nd of October, and I want all the October reports, will you be able to give it to me? No, because the month is not yet, completed. But it means that the most recent, the most up-to-date information shall be available to the consumers when they need it. And sometimes we find that as a challenge. You'll ask sometimes for reports from finance, and you ask them for certain data that might impact the way you calculate your data. And if they don't give it to you on the right time that you need it, you will not be able, for example, to report your data to DOH. So timeliness is just that whenever you need the data, you should be able to obtain it on a timely manner. Okay. Experience means that you're actually measuring the actual performance of for any data that you are collecting, and that you are not, for example, being impacted by, for example, unavailability of data due to your information system and so on. So experience just talks about the use of quality measures demonstrates that it measures actual performance. That's the basic concept of experience. Stability. What does stability mean? What does it mean for data to be stable? Okay, so all of what you said is correct. It's available, it's continuous, it is stable. And here they're saying that we are not always like, I start measuring the complications, the infections rates today, the county. And then tomorrow I will change, I will start calculating the ventilator associated. And then I will say, okay, I don't need this measure, maybe let me start with another measure. You need for the data to be qualitative, that first of all, you're collecting the same measure over time, and you're making sure that the data is stable and available, and it's not eliminated or removed for a long for any reason. The other thing is that the stability is also that if I pull the data today, I should be able to go back and pull a similar data using the same parameters and the same measures tomorrow. So I'm not running different ways of collecting data or pulling reports at all times. Okay. The next point is the evaluability. Okay. And as it says from the name, that the results can be evaluated and can be considered either a good performance or a bad, like worse performance than the previous performance that has been demonstrated. Okay, so for example, if I'm looking at the compliance of the patient with a certain medication, if I see, for example, I had 50% of the patients complying last time, and today I'm having 60% of the patients, I am able to evaluate and see, yes, today is better. If I see that 40% of the patients are responding, then I'd know that my performance today is worse, for example. So I can evaluate progress over time based on the data that I'm looking for. The example they gave in the book was about the complication rate, that lower rate is always better, and you should be able to evaluate that as you have your data trending. Distinguishability. This is talking that the quality measure reveals significant differences among healthcare organizations or others who are being compared with. So your performance can be distinguished based on the data that you are reporting. Distinguished is that they can just compare you, and they could see the difference between your performance versus other organizations. performance. Credibility. Credibility here means is the believability of the data. So that the data, okay. So credibility, that means that your data is truthful, right? It's credible, you know that it's correct, and you could always show it to whoever is asking you without fear of being found out to of worrying that maybe the data, maybe I did not calculate it correctly, maybe I did not do it, and so on. Relevance. Relevance here talks about it should be relevant to actually, the data should be relevant to what you're trying to measure. It's relevant to your patients, it's relevant to your organization, it's relevant to your leadership, it's relevant to your regulators, shareholders, and everyone. Okay, so it is actually, you're not measuring something that has nothing to do with the way you're doing business in your organization or unit. Okay, evidence-based. So many times when we're trying to look for measures, if we're starting a new project or starting a new quality improvement, we try to look at things that are either published on the IHI website or in the AHRQ website. We're trying to look at evidences or resources. We're trying to look at literature maybe that spoke about the same thing and try to collect data that are relevant. So as we said, it should be matching with the scientific evidence and should be also connected to the structure or process or outcome that we are selecting or we are measuring. Last is the reliability, and the reliability means is that the data is free from error. That's the thing you need to remember for the word reliability. Reliability is that it's reliable, you can depend on it, it's free from error, and the way you collected the data, the way that you analyzed the data, and the way that you reviewed your data and presented it is actually reliable over time. And I think I've lost. That's weird. Sorry. Back. Apologies. I think in this slide I've missed two other elements. One is the validity. So the validity of the data means that the measure is that the data actually hold on. The data is actually related to the to what you're collecting or the purpose why you started data collection. And the feasibility, which is it really feasible or easy to get this data or to collect this data? Does it require too much time, too much effort, and so on? Sometimes this happened with us when we're doing quality improvement projects. They would select the data, and when they start collecting the data, they realize that actually it's so much effort, it's so much time, we don't have the resources, or we don't have the tools to actually be able to collect this data, and then they will stop it and they will start looking for another data or measure. So that is for the feasibility of the data. So these are the AHRQ characteristics of quality measurements. Any question on those before I go forward? Okay. Thank you. Now we're going to go to the history of quality measurements, and this will link you back a little bit to when we talked about the history of quality in general. But when they were talking about quality measurements, it's actually the first in healthcare quality. The first quality measurement in healthcare is reference to Florence Nightingale, who was a nurse during the war in England, and she was the first one to report on the mortality rate in the British field hospitals. Her later work and her involvement in quality in her practices was actually what's called now the foundation of the infection control practices, started from there. Later on, it was followed by Dr. Ernest Kodman, who also started linking and collecting data from the mortality, but he was specifically looking at invasive procedures. Okay, and he started looking at hospital outcomes and established some of the earlier structural measures. Do you remember what Kodman theory was when we were talking about the history of quality? The end result theory, where he said that the hospitals needs to monitor the outcomes of the patients they treated long enough to determine whether those outcomes were successful or not, and if it's not successful, why not? And then try to find options or ways of improving in the future. Thank you, Rabab. Then it was Walter Shewart as a data progress. Years later, Walter Shewart started the statistical process control. He started it in the non-healthcare areas, but then the use of the statistical process control became widely used across different businesses. He started it in the manufacturing field, and it later went on across all of the different business processes and entities. Later, we talked about Donabedian, and he actually came up with the concept of structure, process, and outcome. Okay. Then there were two guys called Kaplan and Norton. And if you've looked at those two people, they are the ones who started the concept of what's called the balanced scorecard. And the balance scorecard, for them, they started in the IT sector. The balance scorecard actually looks at, when you're looking at any organization, you need to look at the customer related points, the financial related points. So when you look at customers, it's how do our customers perceive us? When you look at finances, how are we doing financially? You look at your internal processes, what process should we excel in? And then you look at innovation and how you could learn, grow, and do better. And there are two guys called Batilden and Nelson. They've adopted the concept of the scorecards into healthcare, and they brought it into healthcare. They brought it in the forms of scorecards and dashboards. Can anyone tell me what's the difference between the two? Could be. There's another difference because scorecard could be departmental, could be hospital wide, but it's not a wrong answer. But anyone else can guess? We always use it. A scorecard, dashboard. We have a dashboard in the hospital. We have a scorecard in the hospital. We have this dashboard, that dashboard, this scorecard, that scorecard. Anyone kinda, or maybe even on a visual level, can say what would be the difference between a scorecard and a dashboard? Uh, could be. I mean, both could be enough depending on how you're collecting the data and how you're displaying it. It could be. Just scorecards usually look like this. They are divided by themes. You have your targets, your goals, your review frequencies, you have your dates, and then you have them color coded into the what do you call it, the traffic light colors and so on. It gives you an overview of how well you're doing in a certain measure at a certain time and so on. And you could have them as Hannah, you said, organization. You could also have them as departmental. Like if you go to the unit, the NICU, neonatal intensive care, they have their own dashboard or a scorecard. If you're going to ICUs, they have their own scorecards. So a scorecard is as simple as it's a view of the data with the color coding of how well we are performing and so on. Dashboards are mostly related to the way that you look at things. So remember the dashboard in your car, it's kind of gives you more of a visual of how you are doing. You could measure it, and it gives you certain indicators that you could look at. Again, it's categorized into different categories, but it gives you a snapshot of how things are going on at a certain period of time. That's most dashboards do. When you look at them, you could then maybe have, depending on how complex the dashboard that you have is, you could have different filtering mechanisms that could show you different types of time and so on, historical data versus current data. But this, if you see, for example, in the emergency, you have a big dashboard that's showing you now how many patients you have waiting, how many of them have been waiting for how many hours, and what is your current status. Are you currently in the green state? Are you going more to the yellow zone, and things like that. This is on a visual basis, but a lot of people or even a lot of organizations use both of them interchangeably most of the time. But this is what I found while looking at the difference between scorecard and dashboards. Okay. Moving on from there, there has been a lot of movements more recently, since we're still talking about the history of quality measurements in the healthcare, from volume-based model to value-based model. So previously, the physicians were being reimbursed based on how many patients they have treated, how many surgeries they have done, how many, things they have prescribed, and so on, how many patients they have referred. But now they're looking at the value that's being offered to the patients, and they're looking at how many of those patients were actually, received quality care that they deserve. How many of those patients are now infection free? They look at how many of those patients are not having complications after the surgery. So if I do a surgery and the patient ends up having, infection, sorry, we're not gonna pay you. And this is now part of how some of the organizations even pay what they call the performance, pay for performance in the healthcare. Electronic health, the introduction of the electronic health record also improved the collections and reporting of quality measures, but it also had some challenges. Can anyone give me examples of the improvements that have resulted from establishing or introducing the electronic healthcare records? Confidentiality, definitely. You can review Definitely, you can review and revise historical data, specifically if you're looking for certain data in healthcare, and then you want to review what were the reasons or what were the contributing factors. You could always do that. What else? The security of data is definitely there. Someone else was say it again. The volume of data. There is a lot of data that is available now because you're collecting data in electronic healthcare records, and we have aggregated data of multiple patients that we could definitely look at. We know now every and each medicine that's prescribed for every patient. We could look at documents, procedure lists. We could link patient care episodes and events to each other and so on. But what could be the challenges then that came with that? Definitely. There are still partial use of hard copies, or there are missed chances of documentation, and then we don't capture all the data and the details. True. What else? The alerts, which cause sometimes alert fatigue to the end users. There's also the incidence of the copy and paste that could result in error in the documentation. Sometimes you find a patient who's been in the unit for 7 days post surgery, and the document is still telling you day 3 post up, which causes a lot of sometimes errors in the or sometimes copying the same order from one day to another without actually altering it or changing it, resulting in giving the patient the wrong medicine. So who who's that? Someone is speaking and not on mute. Okay. So this is for the history of healthcare quality. Oh God. Okay. We talked about scorecard and dashboards. I want to go a bit faster. I'm taking my time. Okay, we talked about we're going to talk now about the types of quality measures, and here we again talking about the same things. Structural measures. We gave a lot of examples over the last 2 days, including during the test we did this morning, early in the session. Structural measures, for example, the availability of appropriate equipment and supplies in hospital setting, the patient care hours, the staffing availability, all of those things are considered structural. Process could be an example of it is, for example, if you look at the percentage of patients whose hemoglobin AC1 level was measured twice in the past year. So see, if there is an indicator that says something needs to be done in a certain frequency, and you're measuring that frequency, then that is a process measure. An outcome measure, for example, we're still talking about diabetic patients, the average hemoglobin A1C level for populations of patients with diabetes in the past year. So you want to see, have they achieved the outcome required for them or not? Now, these are the new ones, the bundled measures. The bundled measures, these were actually even new for me while I was preparing those slides. So the bundled measures mainly focuses on the bundles. So we have certain care bundles that were applicable or implemented in hospitals. So there are the ventilator bundles, for example, the surgical site infection bundles, the what else was there? Oh God, I forgot all the bundles. Collapse, county, all of those has certain bundles of interventions that needs to be collected and done together in order to prevent the risk of a certain infection or to produce a certain positive result that we're looking at. So one of the bundled measures, and the bundled measures could either be a process, could be outcome, it's just linked to bundle care. So for example, here it says the percentage of intensive care patients on mechanical ventilator for whom all the 4 ventilator bundle interventions are documented. This is one of the process measures. You could also, under the bundle measure, have an outcome measure that says the percentage of patients on ventilator who sustained the ventilator associated pneumonia. Yeah. So the word bundled measures is linked to bundles and care bundles that are implemented within the hospital. Balancing measure. Anyone knows what's a balancing measure? Okay, that's okay. So balancing measure, as Ravab said, sometimes you intend to do something, but while doing that, or while you're trying to improve a certain outcome or a certain indicator, you might actually result in affecting another indicator. So here, for example, is one of those measures. So you look at the incidence of hyperglycemic episodes in intensive care when trying to reduce the number of hypoglycemic episodes. So here, the unit is trying to reduce the number of hypoglycemia they have. They're giving patients more sugar, so they want to make sure that they are not increasing the incidence of patients who are having more of hyperglycemia episodes. Let me give you another example. You are implementing a quality improvement measure on a quality improvement project on the early discharge, like reducing the length of stay for patients. But what can happen sometimes, you want to make sure that you are reducing the length of stay, but you are not increasing the readmission, because the patients are not having complications that's making them come to the hospital. So the balancing measure is going to be the premature discharges or the premature transfers. Then you will end up having other complications because of that. So as we said, balancing measure is always looking at what could be unintended consequences of the quality improvement or the measure that you were trying to collect and trying to reduce. So what they do in the quality improvement projects currently is that they write the goal, the objectives they want to achieve. So I want to reduce hospital stay, the length of stay, but without increasing the readmission level, for example, or without increasing the number of complications post-discharge. Okay. Another measures or another way of addressing measures is what we call benchmarking. Benchmarking easily is comparing performance with competitors. And here, since we're talking about measures, it's mainly comparing like performance results. Now, across DOH, we could compare our performance between our hospital, for example, and other hospitals. If we're looking at internationally, we could go and compare our performance with other hospitals in the world if the data are available. The important things about benchmarking is that we have the benchmarks, so the data are measurable, they are attainable, the data are based on achievements of the highest performance. So I will not go to the worst hospital in the world and start comparing myself with it. I should always look at the highest performer when I'm doing a benchmarking. And then you should always have an appropriate number of cases for analysis. So I cannot compare myself, for example, when I have a very active emergency department with a hospital that's at the rural setting that has an emergency department that maybe sees 10 patients a day, where I see 400 patients a day, for example. So these are benchmarking and the important considerations when looking at the benchmarking exercise. Next, they talk about constructing measurements. And here, what they were basically talking about is how do we represent data? And data are represented usually in proportions or percentage. So usually when we talk about things like 90% of something, it usually is the result of having a numerator and a denominator times 100 or times 1,000, depends on what we're looking for. Ratios are mainly used as structural measures. And ratios is usually displayed in a ratio of 1 to 5, 1 to 1,000, depends, or 1 to 100, depends on what you are collecting. So for example, you could say the nurse to patient ratio is 1 to 5. And that's why we say it's mainly used for structural measures. Means and median, these are usually used for process measures. And they really address, you all know what's a means and a median, right? Anyone can tell me what's a mean? The mean is an average. That's the easy way of just saying it. What's a median? The middle number. So usually for an average, what you will do is you will calculate the data plus like 1 plus 2 plus 3 plus 4 over the number of data points that you had. Okay. While for the median, you will arrange the numbers from the smaller to the biggest, and you will take the number that comes in the middle, regardless what's that number. Okay. And usually these are collected or used when we are collecting or talking about process measures. So the average waiting time to see the patient, the average, or I didn't see median being used as much in data reporting, but mainly the means are commonly used for, and especially if you see any measure that says the average number of so and so, that's what you are looking at the mean. Count is usually used for the surveillances, and it does not allow for a lot of comparisons usually, because it's just a number, and that number does not give you a context of what that number is, but it's used when you have data that is very small scale. For example, if you're having the number of sentinel events in an organization, you expect those to be very less, and it's used or reported as only absolute numbers. Next, we're talking about the timing of the measurements. So, what's a baseline measurement? When do you take a baseline measurement? Anyone? Did you all go to sleep? Mm-hmm. So when do you take it? You just said that before. Yeah. So baseline measures are usually taken before you start an intervention, before you do something. It's the base. You will use it as, your current state of reporting the data. So you would say, I started today and my waiting time is 10 hours before you see a patient, or my waiting time to have an appointment in a certain clinic is 3 weeks. That would be your baseline measures. You take it at the starting point before you implement any interventions or any activities. They only provide you a. Sorry, go ahead, go ahead. What do you mean? You're talking about the previous slide or the baseline? No, the baseline should be a factual data that you collected. So let's say, no. No, it will be based on the actual data you are collecting. So let's say, Hannah, now you want to do a quality improvement project about the compliance with, for example, the compliance with hand hygiene. Okay. The first data you collect, that will be your baseline. So I went today, this month, for example, I collected data and I found that my compliance now is 40%. That's my baseline measure. Okay, so the baseline is the first pretest, yeah, yeah. It's the first data point you collect before you start your interventions and your improvement. That's your baseline. Okay, so your current performance before you implement anything new. They provide, it's just a very standard, it's only snapshot of time. Today you have done this and your score is this, and that's it. It doesn't give you any other data for trending or measuring. Later on now, as you continue to implement your performance project, for example, then you would have what's called trending measurements. Trending measurements are data or measures that you collect over time. Okay? And we do have things like the sometimes you could use data points like a run chart or a control chart. So guess the type of the chart in the image now. This is showing the average length of stay per month, and we can see the dotted line over time. A run chart, a run chart or a line chart, a run graph. Yeah. So it's showing you data over time. Adina, this is what I was talking about when I was telling when you say the bar graph is over time. Actually, a line chart or a run chart is over time. Okay. If I want to make this into a control chart, what should I do? Okay, so I should have an upper control limit and a lower control limit. And the mean, definitely. So usually these upper control limits and lower control limits are statistically designed. There is a certain calculation for it that would give you, based on the data you are presenting, what is the upper and the lower control limits. And this will make your chart look like this, where you have a lower control limit and then a range or a mean, and then the upper control limit. It is. And it's very skewed data. It's not really under control because it keeps flying around, going up and down. So you can see that this process is not controlled at all. Okay, sorry. Okay. Now, there are a lot of data that will come out. Yes, please go ahead. So the run chart would not give you much data. It's only if you're keeping track of data and you just want to trend it and collect it for the base of looking at it. That's it. It does not tell you anything. Now, if the length of stay is 8 or 4, is it good? Is it bad? Does this mean I have a good process or controlled process or not? It just shows you that your data are variable, and it shows that if you look at this, you could easily say that the data is showing that it's being reduced. Yeah. So it doesn't tell you anything. It's the most basic way of looking at data. But if you're really looking at analyzing and statistical and looking at improvements, you would either use the control charts or there is another the Six Sigma charts, which are specification limits. You would look at upper and lower specification limits. What do we want to achieve? What do we want to do? And how do we you work towards achieving that target and reaching to it. So usually the better is the control charts, because it tells you whether your process is controlled. Should you do something to actually fix your process? Maybe now it's the time to train your people. Maybe it's time to add a certain, for example, if we're talking about manufacturing, maybe it's time to stop the machine and do some kind of maintenance to make sure that it goes back and produce properly controlled outcomes or products. So yes, the control is actually more advanced than the run chart. It's a run chart with better specification, if I can say that. Is that okay? You're welcome. I didn't want actually to confuse everyone. Like, for example, maybe if there is a certain data way that you can look at this, And you could maybe, if you look at this, you will find that your upper control limit is 8 and your lower control limit is 4, and your process is within the 8 of 4. So it's considered a controlled process. But actually, if you want to conduct a quality improvement project, you could start looking at your upper specification level. So I might say, as a hospital, I don't want my hospital length of stay to reach 8. I want all of my, the upper specification level to be 6 and the lower to be 2. And I'm gonna aim to make this line come down between the 6 and the 2. So this is even the next step of improvement, is that you define your specification and then you make sure that your data points come down to fit with the specification or with the data that you want to reach to, or to the improvement that you want to achieve. Okay. Now going forward to the interpreting quality measures. So when we're talking about quality measures, specifically when data are being reported to organizations or regulations or to agencies like the AHRQ and so on, they have a couple of ways that they interpret the quality measures. So the first model is called the appropriateness model. It's used by the IHI and the AHRQ. They look at composite scores of performance. So let's say the common thing they have here, or the major thing they have here, is things like treating the patients who are with myocardial infarctions, or treating patients with stroke, or reducing the risk of surgical site infections, and implementing the skip measures. So what they do is that they tell you, for example, for any patient who had a myocardial infarction, they need to have 5 interventions done for them. So I don't memorize them all, but let's say they need to have oxygen on arrival, they need to have aspirin, they need to have an ECG done, they need to have some kind of medication to be given, and they need to have cardiac catheterization done for them in time to, within 90 minutes or something, door to balloon time within 90 minutes. So some of these are wrong. I know there are things related to their discharge and medication they should take and so on, and quitting smoking and so on. But let's say that these are the 5 measures. Okay. The appropriateness model will ask the hospitals to collect the data and look at every patient that had an MI that came to their hospital and see whether all these 5 things were done for the patients or not. If the 5 things were done, they consider yes, pass. If the 5 things were not done, then they are considered, if one of the 5 things is, even one is not done, it's considered none and goes back to 0. So this is one way that they look at the data, and the purpose is they want to make sure that every patient is getting the best and the most optimal care that they could actually get. Okay, this is what's called the appropriateness model, or the all or none approach. Is it clear? Before I move on. Okay, so you have 5 interventions that were defined. The patient gets all 5, you get 100%. The patient even does not get one of them, you get a 0%. There is nothing in between. Okay. The next step is called the 70% standard model. Here, they are not aiming for perfection. It's similar to the appropriateness model, but they are not looking at you achieving 100%. They would say, if you achieve, for example, even up to 70%, I'll consider this good enough. And I would want all hospitals to be above the 70% for me to consider them meeting the standard. So it's just less stringent than the appropriate model that says all or none. The opportunity model is what we mainly know in most of the measures, which is they look at the rate of performance where they would evaluate the, how many opportunities you had. So let's say you are treating you're having patients undergoing surgery. So these are, you had 100 patients did surgeries. These are your opportunities, and then how many of them actually uh, had the surgery without any complications. Okay. Or if we're talking again about the same MI patients, you had 10 MI patients that were admitted to your unit, and then 2 of those MI patients did not actually get a certain medicine, for example. So this is the opportunity model. Is mainly looks at one aspect of care or one aspect of data, and it's the denominator over the numerator when reviewing the opportunities level. You just look at how many opportunities you had and how was your performance or your rate of performance in each one of those opportunities. Almost many of the data we have in healthcare are based on the opportunity model. Appropriateness model and the 70% standard model is mainly used when reporting KPIs on a higher level and interpreting quality measures, at national or international levels, or for like research and other things. Okay. Good. Majority is the appropriateness model specifically for the again the for those measures that has composite scores. Yeah. But again, they also have a lot that are opportunity model. So the composite scores, most of the organization have obtained the composite scores idea from or the measures from the AHRQ itself, and you could find always those MI KPIs, stroke KPIs, and all of those repeated across all hospitals. So they have a mix between the composite score and the opportunity model in the DOH, even previously in Saha as well. Okay. Program evaluation. Now here they're talking about when evaluating quality improvement programs. So you've been working on quality improvement, you've done a lot of initiatives, and you've implemented a lot of activities, and you've been collecting data. For you to evaluate the effectiveness of your program as it's being completed, there are 2 types of evaluation. One is formative evaluation, and the other one is summative evaluation. The only difference I found between the 2 is that formative evaluation is the routine review of the data. So month on month, we're reviewing the data, we're reviewing how well we are doing. Are we improving? Are we not? What can we do each month to actually review it and address the data? And this is where you could use, as we say, the scorecards and dashboards to review those data on a regular basis. Okay. The summative is more of a summary of, and it's used when reporting, for example, annual report. So you're gonna give my infection rate for this year was this much. So you're gonna give the overall result for a year rather than giving month to month basis. And you are driving a summary. It's more formal, as we said, for annual reports, for reporting to the board and stuff like that. You just look at the summary, the high level elements that would address the success of your program overall. Okay. And when you're doing summative evaluation, you're actually going to provide kind of recommendations on future needs of your staffing and additional resources, trainings, and stuff like that the higher boards or the higher management would help you achieve. The last point we'll be talking about today is what we call the quality measurement in the digital age. So there are 3 concepts here: is the big data, the dark data, and the deep data. And even for me, the dark data and the deep data was actually new concepts. the big data is, we always hear it, is that we have a lot of data that has a very big scale, it's diversified, it's complex, it requires new architecture for it to be obtained and collected, and the new algorithms and analytics to be collected. So the big data, now, for example, if you think at the CERNer, the سلامتك, the ملفي that we have, it has, how many data points do you think you have? Is it in billions, maybe trillions, maybe more than that? Imagine every single patient that has gone through the Saha or the healthcare systems in CERNer. Imagine how many encounters each patient had and how many records and data were collected on those patients over time. This is big data. So you have a huge scale, very diversified information, complex requirements. You need to really create a lot of algorithms and analytics to be able to extract your data and bring value from it. Okay, so this is big data, and they talk about what the concept of 4 V's when talking about big data, and in the next slide you'll find that even some people say the 5 V's, but here they're talking about something like the volume. The volume means the amount of data that's available, that's generated, and as we say, like how many patients do we see in a day? In the emergency we see 400 a day. In the outpatients, we see around 2,000 a day, and this is only one hospital. So imagine how many hospitals are using the electronic health records, how many patients they're seeing, and multiply that by every single point of data that's being entered by the registration, by the physicians, by the nurses, by the clerks, by the discharge, by the coding. Imagine like all of that becomes a huge and a big data, and that represents the volume of data. Then second V is the second V is the variety, the variety of data, which is the different types of data. So you have numbers, you have text, you have pictures, you have a lot of data that you have, and then we have the velocity. The velocity then talks about the speed in which the data are being generated. And as we said, as every moment, every minute, every second, maybe a patient is being seen and data is being entered. And then veracity is the accuracy and the reliability of the data that we have and how correct it can be when it is in the medical record. And there was, let me go here. There is another fifth V here. They talked about value, and we'll come back to this. So the value of the information or the data that you have in healthcare. Okay, so this is the concept of big data. So big data is that, yes, we have data that's available, that's huge, and we still need to obtain it, and we're currently learning how to use it and structure it. The concept of dark data then, dark data here, it's unstructured data. It's gathered, but it's not structured. Nobody is really paying attention to it. It's not very well used. And these are the data that are linked with text, images, audio recordings. For example, now many organizations are collecting data from for example, the Apple Watches, or not only the Apple, like the watches, the wearables that we have, that is collecting data on our blood pressures, the heart rate, how many steps that we walked, and so on, biometric data, retinal scans, like whenever you go to an airport or something, there are scans that are being done. So dark data is data that's there, it's collected, but nobody's actually using it or structuring it or paying attention to it, because it's dark, not yet known to the person, not yet really very well explored and addressed. And deep data, so big data and dark data are talking about a lot of data that's being collected in general. Deep data is talking about the large amount of data collected per patient. So for every patient, how deep the data is going, whether it's big or dark. So specific data collected on each patient, and we know that the whether it is the every clinic appointment we go to, whether it is every gym we visit, whether it is any sensor or any device that we are wearing that can collect certain measurement about us, all of that is collecting what's called deep data. So here it's only the emphasis of the quality measurement in the digital age that we're living in now, and the implications they have on the availability of the records that we're looking for. This is more of a comparison between the big data, the dark data. The deep data is not comparable because, as we said, it only relates to a specific patient or specific individual. Here, here it's talking about in big data. Definition is reveals information for making data-driven decisions. Dark data is not yet analyzed, not previously used, not tested, not even sometimes known. The value of the big data, it's useful if analyzed. It only needs to be discovered and analyzed. Dark data could hold value if analyzed, though it's not yet guaranteed. And the dimensions, as we said, the 5 V's here under the big data: volume, variety, velocity, veracity, and values. For dark data, it's traditional unstructured data and or non-traditional unstructured data, and data are available in the deep web, and it still needs to be studied and reviewed. That's the end of our session today. We've taken a bit more time than we expected, but we're finally done. Any questions or clarification? No, please. No questions. Okay. Thank you very much for joining and for being here, and see you next time. Every week there will be an exam. Next week, I'm actually going through an exam, so it might be most probably it will be Rabab who's gonna offering the next session, but I'll be available inshallah to attend as well. Um, let me